Ben, everyone happy? We're all going.
Yes, we're good.
Cool, let's go. So really, this is, I think, almost a redundant talk in a way, because actually the one thing that we're good at is going to be trauma, and I think along the way that's listen. In fairness to all of you guys, I think looking backwards, if I had a child now with upper limb trauma, I'd probably be calling on the senior registrar rather than be going to find somebody in private who's probably done a supracondylar last 5 years ago. So, having said all of that, here is a look at the scope of what we should be dealing with. And we have a couple of scenarios. And I'm starting with this, in that we've got a child, and the guys from Hands know where this is going. It's a southeaster, you've caught a finger in the door. And having done this, we, having caught that finger in the door, what are we going to do about this? And bear in mind that children, particularly under the age of 8, have got regenerative potential. They have the ability to regrow. And my rough rule is that if you have remaining in a child under the age of 8, more than remaining, half or more than half of the nail, that you can lose everything else. And if you have a look at this, and hopefully my pointer is showing up, that tip is gone. Completely gone. The bone is gone, the pulp is gone, and half the nail is gone. But there's enough left behind it to be basically enough to regenerate. And if you just do as little as possible, you're going to have a good result. The thing that's going to stop all of this is, in fact, going to be the injury wherein the surgeon decides now to formalize the closure, because that will abort this natural regenerative process. Our recommendations is you have a semi-occlusive dressing. I'm very happy with something like Gelinet, but Opsite is going to work just as well. And warn the parents that it's going to get a little bit smelly, that if there is a tip remaining, that in fact that tip, having replanted it, and I'm going to talk about that in a moment, that tip is going to go black. It's a biological dressing. It's going to be an environment that will support this regenerative process. And so if you have a little bit of tissue, tack it back on a couple of just stay sutures, positional sutures, and tell the parents, leave it alone. Having said this, if there's a little bit more than that, obviously you're now going down the road that is going to be a reconstructive effort. So less is more. And down here bottom right is the final outcome. And in fact, 2 years ago, I had 2 separate medical students, 6th-year medical, 5th-year medical students, both of whom as children had fingertip injuries. What interests me is, in fact, that we've always said up until the age of 8, and I don't know right now who of you, and I'm looking through the participants, I'm just trying to, who's in Hands? Benjamin, who's there? So, Bradley.
I'm in Hands now, or finishing Hands.
Okay, so what's Mike's current feeling about the regenerative potential in an adult? Do you ever treat these conservatively with an occlusive type dressing? What do you do?
No, not really. Only if they present very, very late and it's almost completely healed and it's not septic. But
okay,
we mostly formalize the adults.
Yeah. Okay, fair enough. Bear in mind that probably the ones that are coming through to the hand units are going to be the more serious ones, and certainly you haven't got the same amount of latitude that we would be applying. But I think mention it to Mike, because I do know that there's been recent work just looking at exactly the same process. Anyway, moving on. The Then quickly, your metacarpal stroke phalangeal fractures, upper, wait. So we've got the kid in the door. The metacarpal phalangeal fractures in a child. Step number one is going to be, have a look at the rotation. Remember that malrotation is going to annoy your patient intensely. They're going to remember your name because you are going to be the idiot who has left them with this deformity that every time that they try and clasp something, they're going to overlap. And to me, there's a natural palisade. And one of the things that I hate about these Zoom meetings is not being able to show you. But you get the impression here that your fingers should be converging somewhere to the base of the scaphoid. And obviously, finger number 3 is out. What I do in addition is I flex the MCPJs, metacarpal phalangeal joints, straighten the interphalangeal joints, look at then the fingers end on. Do it yourself in front of you. And you're going to see that the nails should all line up. And if there's one that's obviously out of place, bearing in mind that this will work for the phalanx, but not the metacarpal. If there's one out of line, then you're going to need to reduce it. And if you need to reduce it, it makes sense. You're going to put in a digital block. I'm not going to go into how to do that. You're going to then basically easily derotate and buddy strap as such. You're going to hold it in position. And Martin Singer and Mike's whole philosophy is that hands you must mobilize, and so exactly that applies here. I'm fairly lenient so long as I think that parents are going to listen, and you need to judge it. But to say this to the parents that probably 4 weeks is going to be enough time, that the child can mobilize, I generally use this zinc oxide type tape, strap it up. So I'll get a pen, I'll get the parent's pen, and I'll get a spare piece of tape. I'll wrap it up enough that they've got spare to be able to make 2 or 3 changes. And then basically, I would be happy if I trust them, discharge. Otherwise, I'm going to see in a week's time, just check that everything's going okay. There's this concept then, a very particular fracture. We call it, it's got a name, and I don't expect you to remember it, but it helps you to remember how the thing happens. The extra octave, you sliding from low to high C, and you pull this finger, causing, I hope I've got a photograph here, there we go, is now a Salter-Harris 2 of the base of the little finger, extra octave fracture. The trick here is this, is that if you want to reduce it, you're going to it's quite difficult, particularly in children, to actually manipulate this. And the trick really is to put a pencil in between, put that digital block in place, and then use the lever in between your ring and little finger in order to reduce buddy strap, etc. I'm not quite sure what this quiz and questions is. And now you're going to have to just give me a moment while I now hunt down the my lateral condyle talk. The questions in the meantime, comments. Benjamin?
Yes, boss.
Any questions in the interim?
Not for now, please.
Okay. Badges. Sorry, I'm just now finding this previous talk. Okay, so Benjamin, quickly just start for me, because this is now the Cook's tour. The upper limb fractures starts, just run through online with me. your treatment of clavicle fracture from the beginning? What are the two big groups? What ages are they going to occur?
Neonatal injuries.
Okay, tell us a little bit about that. Where are we going with it?
So the neonatal injuries are usually birth injuries, and that is usually treated conservatively.
Okay, why does it happen?
Usually from during the birthing process, from shoulder dystocia sometimes.
Got it.
With the presenting shoulder.
Yeah.
And then with the malhandling of the.
Why? Why?
Why
does the baby get stuck, Benjamin?
Pardon?
Why does the baby get stuck?
Either the baby's too big for the pelvis, or well, and then the gynecologist would want to use some instrumented, and sometimes that gets caught in and probably causes some injury as well. But that's a bit far-fetched.
Okay. So they're big babies. They're big babies, that's why they get stuck, usually. Difficult prolonged labor. And a big baby goes hand in hand with obstetric gestational diabetes. I'm trying to get to a point is that by the time you get stuck and you've got a clavicle fracture, what else are you going to be looking for, Ben?
Do you mind repeating that? I didn't get that, sorry.
So you've got a baby, you've got a neonate, it's day 3, you've been called to the nursery, you've got a clavicle fracture. What goes through your head?
Obstetric birth palsies, neurological.
Correct. How are you going to check for it?
You can try to extend the elbow for a baby by flexing the shoulder to about 90 degrees and then try to see if the child extends the elbow against gravity.
Okay.
If they don't manage to do that, then you can suspect it.
Okay, so you're flexing elbow, yeah, biceps.
Yeah, so that's checking biceps.
Okay. Anything else? Biceps deltoid.
Biceps and deltoid, yeah.
Let's say they're not there. What are you going to do? I mean, there's a fracture. The child's not going to want to be moving.
You can also do a Moro reflex.
Okay, they're still not moving. It's painful. What are you going to do next? You're going to send them to Mike Sullivan's. You're going to do a nerve transfer. You're going to do tendon transfers. Where are we going to go?
Well, you want to observe in the first 3 months to see if there's any recovery.
Okay.
Or to what and then to be able to determine where your injury, or to be able to identify your injury.
Got it. Okay, so basically 85% are going to resolve spontaneously. That's the sort of rule. Bear in mind, by the way, that although they resolve, there might be later demonstrable differences in strength. So it might not be complete resolution, but you're not going to jump in if they have return of biceps and return of deltoid. So just roughly, because they've already seen me in the clinic and they've got a pathway, for me it just makes sense that I see them at 1 month, then at 2 months, then at 3 months. And if they then, that part of that 15% that are not resolving, then I'm going to send them on to a hand surgeon like Solomon's, a unit where they can deal with it. And along the way, in the interim, treat with tubing grip and a body sling. I normally get the physiotherapist involved mainly for range of motion. And I don't really think it's going to make a big difference in the 85%ers, but I think to start early and get it as a sort of almost a pattern in the 15%ers, it makes sense to me to start that part of it early. Right, are you seeing my screen, Ben?
Yes, boss, I can see that.
Cool. And so then the adolescents, the current treatment, and Stu Mears and I went through this. He said that that old traditional figure of 8 is child abuse. I kind of agree with him. It's actually very uncomfortable. And so current policy, treat with a sling. Andrea makes a point that in an adolescent or an older child, these injuries they're going to heal. We don't need to re-x-ray them. And so once again, you can probably tell the parents, look, you've got the clavicle fracture, you need to have a collar and cuff for 3 weeks. And in particular, if they're from far away, I'm very happy that they get a brief note or a discussion with the parents that this is going to be self-limiting. They can take it off themselves. Don't come back and burden the clinic. So here's a proximal humerus fracture. You guys know this, this is also bimodal distribution, both birth trauma, same story about the obstetric injury. The remodeling potential of the metaphyseal injury in a proximal humerus fracture is enormous. Benjamin, I'm just picking on you tonight, but why? Why so much healing potential at the shoulder?
Because I'd say the blood supply is rich in that area, in the metaphyseal region.
Okay. So why then does your proximal femur not remodel as dramatically? It's got more blood supply.
Also, I think the position of the deformity is in the plane of movement. So then,
okay. But once again, you could argue the same thing for the femur, and it doesn't seem to remodel as well. So I agree with you that the clinical outcome, the impact of the mul unit of proximal humerus is actually very good. But it's still nonetheless, I mean, look at this thing. This is completely off. Is probably what, 45 degrees angulated. And if you look carefully at 2 years, you're going to struggle to pick up the fact that there was a fracture at all. The reason is this, is that you're in contrast to the lower limb, where most of the growth occurs around the knee, roughly 80%, distal femur, proximal tibia. The upper limb, the growth is proximal humerus, distal radius ulna. And it explains, by the way, why your commonest site for an osteosarcoma in a growing bone occurs around the knee. Distal femur, number 1, proximal tibia, number 2, but the third most common site is going to be your proximal humerus in terms of long bones. It's all about growth, and the fast growth is what remodels your distal radius, your proximal humerus, and you know, probably if we could leave it alone long enough, your knee. Humerus shaft, we all know about this. The lookout for the radial nerve injury. It is hidden away by this, the fact that you've got a sling. And they're all going to recover. So long as you've got a closed injury, there's no indication to go in and explore it. But you look like an idiot when you're suddenly faced with a mother at 4 or 6 weeks, you've taken the U-slab off and there's a clear wrist drop. Because she's lost confidence. So the father's lost confidence because you're the idiot who never picked it up in the first place. Relatively unusual in a shaft fracture in children, more common in the adult, but just look out for it. Is there anything else to say? The treatment in a U-slab is dependent on the fact that if you just make this lateral part of the U straight, you are going to end up with the chest wall forcing the fracture into varus. Well, it's not the end of the world. You can tolerate 30, 40 degrees of various, but it's unsightly. And if you want to prevent it happening, consciously remember that in fact, you want to be molding this U-slab intentionally into what you think is going to be valgus. They're going to cancel each other out, and you're going to get a limb that is straight. So those two guys in trauma at the moment, this is the outcome of a missed untreated compartment syndrome. Fortunately, we see very few of them. We have not, that I can recall in recent years, had a missed local compartment syndrome, but we need to be on the lookout. We went through it today. The fact is that, to me, the cardinal signs are going to be pain on passive stretch, disproportionate pain, and that vague entity of the woody hard compartment. The others, so far as I'm concerned, the poikilothermia, the paresthesia, they might or might not be present, but I'm not going to rely on them primarily as my diagnostic criteria. We don't use pressure monitoring, and I think that if you use pressure monitoring, two things must happen. You must be familiar with the equipment, whatever it is you're using. I do think you must think about using it often, and in an individual patient repeatedly. So I think that the primary diagnosis is going to be clinical, and definitely for a fracture around the elbow, that we are not going to use a circular cast. And then just very briefly, while I was trying to keep Benjamin at bay, we're going to have your supracondylar group. Where our current policy is that the grade 1s, undisplaced, we're going to treat either with a back slab and a collar and cuff, or with a collar and cuff alone. We're not going to re-x-ray them. They're going to go on, they're going to heal, and they're going to be fine. The grade 2s, we are unusual in that we will treat the grade 2 supracondylar fracture so long as the anterior humeral line is bisecting the capitellum. We are happy to treat them conservatively, which is not the case with all of the units. So just be aware of this. And in order to make sure that they're not slipping, bring them back at a week's time, re-x-ray them with a lateral x-ray only. And then the grade 3s we're going to pin. Current is standard, is that we're going to go with 2 lateral pins to avoid the medial pin, because we've got an 8%, round about an 8% incidence of a transient iatrogenic almond nerve palsy. So go for the lateral pins. Having said that, if you've got a completely unstable fracture, if it's rotated, if you're in trouble, I don't think that it's going to be the end of the world, either temporarily or to completion, to have a medial pin. But I think where possible, try and avoid the medial pin altogether. So then the next group is now going to be the lateral condyle, a Jakob classification. You're undisplaced less than 2 millimeters on any view. Is treated conservatively. And once again, you get your initial x-rays, AP, lateral, and obliques, because you want to know on any view, is there displacement less than 2 millimeters or not? And if there's less than 2 millimeters of displacement, bring it back in a week's time, have a look at it, it's not shifting. Those that are more than 2 millimeters, we're going to fix with reduction and pinning. Now, once again, traditionally, we would have opened all of them. Remember that the lateral condyle derives its blood supply from an end artery. Don't go all the way around the back and occlude that artery. You're going to get avascular necrosis. And so traditionally, we would have opened all of them. But a few years ago, Stewart Mears and I started just toying with the idea that some of these you may be able to manipulate closed and having reduced that fracture gap to less than 2 millimeters, pin inside to one transverse, 145 oblique up. So once again, Benjamin, your mechanism of injury in the lateral condyle fracture, if we go with the concept that you're trying now to gain a closed reduction in the Jakob 2, that is, that you are displaced more than 2 millimeters, but not completely detached and dissociated and swung around. What's the usual mechanism of injury, Benjamin? Ben's gone.
I'm here, boss.
Oh,
I think
are you just thinking?
Mike was mute.
Open book exam.
Sorry.
Yeah.
So it's usually a push-off injury from an axial load?
No, so it's usually actually a pull-off. Yeah, it is, I promise. Go look it up.
Yeah. Okay.
So it's normally a pull-off. So therefore, if it's a pull-off fracture under the action of your common extensors, then it kind of makes sense that initially, if you're trying to reduce it, you're not going to go into varus but valgus. Just remember that, okay? And you'll see it because the muscle action tends to pull that fragment down and around. But yes, I agree with you. There is a subgroup that are going to push off valgus type injury. Most of the time, that's going to be varus. Doesn't really matter. I think that once you're in theatre and you've got screening, you can do both. And I've got these right at times, but not always. Using your thumb to push on that fragment, usually a little bit of now valgus rather than varus, manipulates until you've got an acceptable reduction and then pin in situ close. But if you're not getting it right, and sometimes you just don't, then to open them. We had one recently, and I can't remember who it was. I think it might have been Rafik, who was disappointed because he felt that now he hadn't quite got that sort of lateral closure. And I was trying to explain that, in fact, because this is a pull-off fracture, often, while your joint is, in fact, the hinge about which this rotates, your joint is going to be fine, even though that proximal and lateral section of the lateral condyle fracture is not perfectly reduced. It's going to be okay because the part that you're trying to close is the furthest away from the fracture. So don't worry about that too much. And then obviously the spun around 3, you're going to now reduce, make sure under vision has to be opened. Under vision, is the joint closing, yes or no? If you really want to satisfy yourself on occasion, but just be careful, you can add Conray into the joint just as an arthrogram. It's going to show you pretty clearly enough. I've got a photograph and I meant to get it, and I haven't got it for you at the moment. Just to show you, to clarify the fact that you now will get joint congruency. I don't think it's necessary in all cases, but it's a sort of thing that might add a little bit to basically to your armamentarium. And then we have the displaced radial head fractures. So I've said to refer on, but your displaced radial head fractures, I still go with a 30-30. So I will accept 30 displacement % and 30 degrees of angulation. The gray area is the 30 to 60 group, and definitely over 60 is the group that you're going to be reducing and fixing. And once again, I tend to be a little bit more aggressive. It just makes sort of sense that we start manipulating after the 30-30. Remember again that the elbow has got less remodeling potential than the distal radius of proximal humerus, and so maybe we need to be a little bit aggressive. I'm not going to bother you with the supracondylar sail sign. Just a quick word about the forearm fractures, and we know this, that Rockwood's got a whole chapter. It goes backwards and forwards as to whether or not your distal pronatus or your pronator quadratus is going to be a deforming force. Is it your proximal pull? Or biceps? Is it both? Is it neither? In my head, to me, I would simplify the whole thing in the forearm fracture and say that to me, that number one, if you just get the apex on reduction, pointing down, it's going to mean that your supination injury is pronated and your pronation injury is supinated. It works. And having done that, be aware that you then are going to be, whichever you've done, pronation or supination, you've now reduced the mechanism of injury, your reduction, your 3-point reduction is going to have its apex towards the ground. So your thumbs, if you wish, are going to be towards the ground. There's a long thing, but you get the point. Having done that, I would prefer, and I know that you guys are going to tell me that there are good studies to show that a below elbow cast can be enough. It can be. But I think that if you are unsure of yourself, if it's difficult, if you're new, I would prefer for now for an above elbow plaster. One of the reasons being is you can't control pronation, supination unless you've got above elbow, and it's a kind of one size fits all sort of rule. You can start chopping and changing later when you become more experienced. What's definitely important is that the molding occurs at the apex of the deformity. So I've got all of these pictures. You've all been through this. Now, just be careful here. So here is going to be our 3-point molding, and this is perfectly adequate, perhaps, for now your mid-fracture radius and ulnar. What I think often happens though is that in a very distal metaphyseal fracture, that you must assess where the metaphysis is, and I'm not sure if I've got X-rays to point all of it out. But let's just look at this for a moment, because let's forget that this is a forearm fracture. This to me would be good molding for your distal metaphyseal fracture, because your apex of the molding is going to be far away from the apex, which is normally apex volar and dorsal displacement of the fracture itself. The reason I'm pointing this out is a lot of the time, and I've shown this to many of the registrars, is in fact when you look at your very distal molding, that in fact is reversed. It is pushing your metaphyseal fracture out of position, and in fact is making things better, not worse. So have a look over here. If what you guys commonly do is start applying, and let me just, I don't find a means, here's a pen. So Benjamin, can you see,
Boss, we can see your pointer.
You go and see the pointer. So if my molding for this particular fracture occurs anywhere from there to there, then in fact I'm pushing it back out of the way. You got it. So for me, this fracture requires for the proximal molding, the volar molding, to occur far away, distal to the fracture site. That'll allow your other hand to sit up here. And I know I'm sticky about this, but honestly, 8 times out of 10, when we're sitting in the clinic and we've got this apparent new slip or a slip in the fracture, if you look at the molding critically, you'll see that in fact your hands are bunched up here and here, and 8 times out of 10 is reverse molded. Okay, so we've got that. And even this, I would have preferred for this molding here to have been mid forearm and there and there. We've been through the metacarpal phalangeal fractures somewhere. I've done that. I've done that. That's it. What we've left out are the carpal bones, very uncommon in children, do happen. Look out for them, particularly in the older child, the adolescent scaphoids. by the time you fracturing those bones, the treatment is going to be analogous to an adult. So it's going to be that question of vigilance, of reduction, and probably fixation. Base of thumb, very similar concept, is that by the time you're fracturing that Bennett type, it's going to be an adult type treatment protocol. I'm just trying to work my way through the rest of it. Ben, anything else? Any questions? I know it's been a little bit here and there, and I apologize for that. Having said that, yeah, questions?